Hey guys, welcome to my 10. So in this video we are going to look at the pharmacology part of the uterine relaxants, that is tocolytics, as well as uterine stimulants. So let's get started. So uterine relaxants, they are also called as tocolytics. So what are tocolytics? They are those drugs that inhibit the uterine contraction. So whenever the uterine contraction is there, these tocolytics will help to inhibit the uterine contraction. So what are all those? First group of drugs we have called as the prostaglandin synthesis inhibitors. So they are the non-steroidal anti-inflammatory drugs called as indomethacin, paracetamol, and other drugs. So they are the prostaglandin synthesis inhibitors called as non-steroidal anti-inflammatory drugs, indomethacin. So what is the mechanism of action of these drugs? They help in the inhibition of prostaglandin synthesis. Now what are they used for? They are used for the relief of dysmenorrhea and not to delay labor. So for the relief of dysmenorrhea, that is painful menstruation, so they are useful in that. And what are the adverse effects we have? We have the premature closure of the ductus arteriosus as well as the pulmonary hypertension. So the adverse effects of using these prostaglandin synthesis inhibitors is that they will cause the premature closure of the ductus arteriosus as well as the causing pulmonary hypertension. So because of these adverse effects, they are not used. So moving on to the next class of drugs, that is the calcium channel blockers. Calcium channel blockers, example nifedipine. And what is the mechanism of action of these? So they help in by inhibiting the influx of calcium into the myometrial cells. So for every contraction we need calcium, right? So calcium channel blockers, they inhibit the influx of calcium into the myometrial cells, so thus blocking the uterine contractions. So thus they are used as the tocolytic. So moving on to the next group of drugs, they are the beta adrenergic agonists. So what are the examples of beta adrenergic agonists? We have salbutamol, terbutaline, ritodrine, as well as isoxsuprine. So what are the beta adrenergic agonists we have? Salbutamol, terbutaline, ritodrine, as well as isoxsuprine. So what is the mechanism of action of beta 2 receptors? They cause vasodilation. And what are the side effects? We have tachycardia, palpitations, arrhythmias, pulmonary edema, hyperglycemia, as well as hypokalemia. So we have, these are all the side effects, that is the tachycardia, palpitations, pulmonary edema, hyperglycemia, as well as hypokalemia. So thus they are contraindicated in pregnant women with diabetes as well as heart disease. So we will not give beta adrenergic agonists in pregnant women with diabetes as well as heart disease. Moving on to the next one, that is the atosiban. So what is atosiban? That is the oxytocin receptor antagonist. So that is an important drug, atosiban. So what happens? It competitively blocks the oxytocin receptors of the uterus. So it blocks the oxytocin receptors of the uterus and thus producing the uterine relaxation. So it is an important drug, remember that, atosiban. Moving on to the next group, that is the magnesium sulfate. So magnesium sulfate is useful when beta 2 agonists are contraindicated, that is those pregnant women who have heart disease and diabetes. If they are contraindicated, we can give magnesium sulfate, and this is given by IV. So magnesium sulfate has a depressant action on the uterine smooth muscle, CNS, as well as the myocardium. It has a depressive action on the uterine smooth muscle, CNS, as well as the myocardium. Thus they are also used to control the convulsions and BP in pregnancy. So we can also use it to control convulsions and BP in pregnancy. Now what are the side effects of magnesium sulfate? It causes hypotension, hypothermia, cardiac arrhythmias, CNS, and respiratory depression. So it causes hypotension, hypothermia, cardiac arrhythmias, CNS, and respiratory depression. Now what are all the other drugs that we can use as tocolytics? We can use progesterone. So it has a relaxant effect on the uterus. We can also use nitric oxide donors, which has a tocolytic action as well. We can also use halothane, which is a potent tocolytic effect. So what are the use of tocolytics? As I just told you, to delay the preterm labor, for a threatened abortion, as well as dysmenorrhea. So for all of these reasons, we can use tocolytics. So these are all the important group of drugs as well as examples, their mechanism of action as well as side effects. Now let's move on to the uterine stimulants. So what are uterine stimulants? Uterine stimulants are also called as the oxytolics or ecbolics. They are called as the oxytocics or ecbolics, not olics, oxytocics or ecbolics. So these are the drugs that cause uterine contractions. They help in contracting the uterus. So what do we have? Firstly, we have the oxytocin, which is very important. Then we have the ergot derivatives, that is the ergometrine and methyl ergometrine. Then we have the prostaglandins, that is the PGE2, PGF2 alpha, and also PGE1, that is a misoprostol. So these classification of drugs are very important for your UG examinations. Make sure to understand them. They are the toxin, ergoderivatives, that is the ergometrine and methyl ergometrine. Then we have prostaglandins, that is PGE2, PGF2 alpha, PGE1, that is the misoprostol. We'll learn about the oxytocin. So what is oxytocin? We know that the oxytocin is synthesized in the hypothalamus and that is stored in the neurohypophysis of the pituitary. So it is synthesized in the hypothalamus and stored in the neurohypophysis of the pituitary. And what are the pharmacological actions of the oxytocin? In the uterus, it stimulates the contraction of the pregnant uterus. Unpregnant uterus has no responsive to the oxytocin, whereas in a pregnant uterus, it stimulates the contraction of the pregnant uterus, and the non-pregnant uterus is insensitive to the oxytocin. So what does it do? It increases both the force as well as the frequency of uterine contractions. Both the force and the frequency of the uterine contractions, both of it increase using the oxytocin. Now what is the mechanism of action of oxytocin? Oxytocin binds to the GPCR receptors on the myometrium. GPCR receptors on the myometrium, thus generation of the inositol triphosphate. And does it generate inositol triphosphate? This will help in the release of calcium from the intracellular stores. So thus increasing the production of prostaglandins by endometrium, causing contraction of the pregnant uterus. So the mechanism of action of oxytocin in the uterine contraction is very important. Let's look at it. Oxytocin binds to the GPCR receptors on the myometrium, generating the inositol triphosphate, releasing the calcium from the intracellular stores, increasing the production of prostaglandins by endometrium, and causing the contraction of the pregnant uterus. So this is the mechanism of action of the oxytocin. Now let's look at its effect on the breast. On the breast, it contracts the myoepithelial cells of the breast and causes milk ejection. So oxytocin again is an important milk hormone. It contracts the myoepithelial cells in the breast and causes milk ejection. And finally, its effect on the kidney. In the oxytocin in high doses, it also affects kidney, causing decreased urine output. So only in high doses it affects the kidney by causing decreased urine output. In the CVS, what do we have? Again in high doses, oxytocin causes peripheral vasodilation. So these are all the important effects of the oxytocin in the uterus, breast, CVS as well as the kidney. Now let's look at the uses of oxytocin. As I just told you, oxytocin is useful in the induction of the labor. If the labor process is taking too long than expected, then the doctor will give oxytocin to help in the induction of the labor. Then prevention and treatment of postpartum hemorrhage. So postpartum, after the delivery of the baby, if the mother is bleeding too much, it also helps in the oxytocin. How does it help? Because of by contracting the uterus, those muscles will contract and they will block the vasoconstrict the arteries, uterine arteries. So they help in the prevention and treatment of the postpartum hemorrhage. They also help in the increasing the intensity, frequency, duration of the uterine contraction. So as I just told you, they cause uterine contractions by increasing the intensity, frequency as well as the duration of the uterine contractions. And they also help in the breast engorgement. That is we have intranasal oxytocin which helps in the breast engorgement. So what are the side effects of the oxytocin? Let's look at it. It causes uterine hyperstimulation, so causing it uterine rupture, fetal asphyxia and fetal death. So when we give too much of oxytocin, it causes uterine hyperstimulation, causing irresistant contraction of the uterus, and this will lead to uterine rupture, fetal asphyxia as well as fetal death. Then you can also cause water intoxication. As I just told you, it decreases the urine output, right? So it may lead to water intoxication, causing headache, vomiting as well as drowsiness in the mother. Then it also causes hypotension as well as reflex tachycardia. So it causes hypotension, and this hypotension will lead to reflex tachycardia. So this is about the adverse effects of the oxytocin. So thank you guys, thank you for watching video till the end. Make sure to subscribe and hit the like button and share this video to other friends who want to learn more about the pharmacology. If you want to get access to these notes, make sure that you click the link in the channel description. Go to my channel, go to the description, there is link on the community, so click on that and you can get access to these notes. And there's also link for the Instagram. Make sure to follow me on Instagram to get access to these notes. So thank you, and I'll see you in the next video. Bye.